I request everyone to assemble the amphitheater for the next session.
Welcome back, everyone. I hope you enjoyed the break. Let's dive right back in with our next session on tension type headache. Our next speaker is Dr. Archana M., consultant neurologist. Dr. Archana had done her MBBS from Government Medical College, Alappuzha, MD from Pushpagiri Institute of Medical Science and Research Institute, Tiruvalla, and DM from Tirunelveli Government Medical College. She has extensive training and a strong academic background and has made significant contributions to the field of neurology. So let's welcome Dr. Archana M. This session will be chaired by Dr. Philip Thomas, Department of General Medicine, Believers Church Medical College Hospital, Tiruvalla, and Dr. Fahmi K., Consultant Family Medicine, Muthoot Healthcare, Korancheri. I welcome Dr. Philip Thomas and Dr. Fahmi K. to chair this session.
Good morning. Next, we are going to discuss about tension type headache. Tension type headache previously was also known as stress or tension headache, muscle contraction headache, psychomyogenic headache, or psychogenic headache. Tension type headache, as we all know, it is the most common primary headache. In fact, it is the most prevalent neurological disorder. The characteristic feature of tension type headache is that it is relatively featureless, and it is one of the least studied of all primary headache disorders. It is because of this that the ICSD-3 had classified this as a primary headache to promote more research, but still it is the least studied of all primary headache disorders. Coming to the epidemiology, it is found in 30 to 78% of the population. Females are found to have a slightly higher prevalence than males. When we see the prevalence, we see that it starts during the adolescence, it reaches a peak in the fourth decade, and gradually it will decrease thereafter. But there are a minority of unlucky people who continue to have this headache even in their older age. The impact of tension type headache is most greatest on this older group of people. Coming to the classification, tension type headache is divided basically into two types: episodic tension type headache and chronic tension type headache. Episodic tension type headache, based on its frequency, is again classified into two: infrequent episodic tension type headache and frequent episodic tension type headache. In infrequent episodic tension type headache, the patient will have headache episodes less than 1 day per month. That is, patient might be having the headache once in 45 days or once in 2 months, like that. But in frequent episodic tension type headache, the patient will have episodes from 1 to 14 days a month. Chronic tension type headache is characterized by having headache episodes in 15 or more days per month. Now, each of these type of headache, that is, the episodic tension type headache and chronic tension type headache, is again subdivided into with and without pericranial tenderness. There is also another entity called probable episodic tension type headache. In that, the headache features will meet all criteria except one in the ICSD-3 criteria for tension type headache, which we will discuss later. Coming to the pathophysiology. Tension type headache, the pathophysiology of tension type headache is exactly not clear. It is said that it is likely to have a multifactorial origin. As far as episodic tension type headache, the most important factors contributing are environmental factors and also the peripheral activation or sensitization of the myofascial nociceptors. Whereas considering the chronic tension type headache, what matters is the sensitization of central pain pathways, which forms a major role, and a minor role by genetic factors. We have to note that genetic factors play only a minor role in tension type headache, especially chronic tension type headache. In episodic tension type headache, what happens is that there are many peripheral nociceptors. When there is persistent activation of these peripheral nociceptors, it will lead to activation of the trigger points and activation of the peripheral nociceptor sensitization. As a result, these in turn will sensitize the second order neurons of trigeminal nucleus. That is the basic pathology that occurs in episodic tension type headache, whereas that is the ascending part. Now in chronic tension type headache, what happens is that there is a central nociceptive inhibitory pathways are becoming deficient. So the central pathway has got, it usually inhibits the pain. That is becoming deficient, and so we are getting the chronic tension type headache. So when in patients with chronic tension type headache, it has been found that they have increased sensitivity in tendons, muscles, ligaments, etc. And this increased sensitivity is significant in the pain becoming chronic. And when we compare the pain threshold in this patients with tension type headache, it is found that in infrequent tension type headache, that is patients who are having less than one episode in per month, they are having normal pain threshold. But in patients with frequent tension type headache and chronic tension type headache, the pain threshold has also been decreased. So in one study where they found that the trigger points were they triggered, and the referred pain elicited from the trigger points, the pain that resulted from it simulated that of the chronic tension type headache. So what was concluded was that the continuous painful input from pericranial myofascial tissues will lead to central sensitization, so that the stimuli that are normally innocuous, that is not pain, are also misinterpreted as pain. Now, what are the risk factors that cause tension type headache? Female sex, younger age group, fatigue, sleep disorders, migraine history, depression. These are the risk factors associated with tension type headache. When educational level was seen, it was found that educational level has been positively correlated with episodic tension type headache, but negatively with chronic tension type headache. Now, coming to the clinical features of tension type headache. Pain in tension type headache is usually mild to moderate intensity, and it is a non-throbbing headache, unlike migraine. It is bilateral or holocranial. Other features like photophobia, phonophobia, nausea, vomiting, autonomic signs like conjunctival congestion, tearing, nasal congestion, all those will be absent in tension type headache, but exceptions are there which we will discuss with ICSD-3 criteria. Increased pericranial muscle tenderness is the most important abnormal finding in tension type headache. Now, how does the patient describe this tension type headache? They will say that they are having a dull pain, there is a pressure overhead, there is a head fullness, head feels large, there is as though they are wearing a tight cap, there is a band-like feeling, it is as though they are having a heavy weight on my head or shoulders. These are some of the ways that patient will describe tension type headache. So, in order to, as I already said, pericranial tenderness can be seen. The pericranial tenderness can be elicited even when the patient is not having an active tension type headache. So, how do we elicit that? For that, using the second and third finger, we'll manually palpate by small rotating movements over the frontal temporal, masseter, pterygoid, sternocleidomastoid, splenius and trapezius muscle. This will elicit the pericranial tenderness. But what we have to understand is that tender muscles are not the sites of ongoing inflammation. There are, because it has been found that the interstitial levels of inflammatory mediators and metabolites are actually normal. Now, what are the precipitating factors for tension type headache? Stress and mental strain, head and neck movements, sleep disturbance, dehydration, alcohol, sunlight exposure. These are the precipitating factors for tension type headache. Now coming to the diagnosis of tension type headache. First is from the history. Neurological examination will be mostly normal, except that there will be increased tenderness of the pericranial myofascial tissues and presence of trigger points. What we have to note is that it's very unlikely that the patient will come to us with a presenting complaint of infrequent episodic tension type headache. So when patient comes with a tension type headache, always rule out secondary headaches as well, especially medication overuse headache. Now coming to the ICHD-3 diagnostic criteria for episodic tension type headache. There are 10 episodes of headache. Each should last for at least 30 to 7 days with 2 of the following. That is, as I told, it's bilateral in location. Unlike trigeminal autonomic cephalgias or migraine, it is pressing or tightening quality. It is never throbbing, unlike migraine. And also it has got only mild to moderate intensity. And it is not aggravated by routine physical activities such as walking or climbing stairs. The speakers before me has already told that in migraine, like patient would like to sleep in a very calm and quiet environment. In autonomic cephalgias, they will be very agitated, moving about. But tension type headache is characterized by the fact that in spite of the patient having headache, they will be able to move about and do their routine activities. Physical activities never hampered by tension type headache. And along with the above criteria, they can have both of the following. That is, patient should not have nausea or vomiting, and they can have preferably they should not have photophobia or phonophobia. If present, only one should be present, not both. So what you have to notice that it is not localized. Tension type headache is not a localized type of headache. It is never throbbing, it is not severe, and it is not aggravated by activity. Then infrequent episodic tension type headache and frequent episodic tension type headache I have already told. Now coming to chronic tension type headache. Now, chronic tension type headache means headache lasting hours to days or unremitting in more than 15 days per month for more than 3 months, and at least 2 of the following. That is again bilateral location, pressing or tightening quality, never throbbing, mild or moderate intensity, not aggravated by routine physical activities such as walking or climbing stairs, and both of the following. No more than one of photophobia or phonophobia, and here mild nausea is allowed. In chronic tension type headache, patient can have mild nausea, and neither moderate or severe nausea should be allowed, and vomiting is also not allowed. So now we have got a patient who is meeting criteria for both tension type headache and migraine. Then what do? Then as per ICHD-3, we have to say that migraine will supersede tension type headache as diagnosis. Now if you have got a patient who meet criteria for both tension type headache and probable migraine, then treat it as episodic tension type headache. Now there is a patient who is meeting criteria for both chronic tension type headache and medication overuse headache. Then we should diagnose that the patient is having both and treat both. Now after the successful treatment of medication overuse headache, again reevaluate the patient. Then at that time patient may be classified as having episodic tension type headache alone. Now comparing migraine with tension type headache, the number of frequency of attacks is different in both. In migraine it is 5 attacks lasting for 4 to 72 hours, whereas in tension type headache, to diagnose that, there should be at least 10 attacks lasting for 30 minutes to 7 days. And migraine is usually unilateral, pulsating, moderate to severe in intensity, prohibiting activity. Whereas as I already told, tension type headache is bilateral, not pulsating, mild to moderate intensity, and does not affect the physical activity. Nausea, vomiting, photophobia, phonophobia are all seen in migraine. But if it occurs in tension type headache, either of photophobia or phonophobia alone is allowed, and also patient should not have any nausea or vomiting. In chronic tension type headache, patient can have mild nausea only. Now, coming to the diagnostic testing, usually if the patient is having a stable headache of 6 months or more, imaging is not indicated in tension type headache. However, if you have an unexplained abnormal finding, or if there are atypical headache features or features not typical of primary headache, or if there are any red flag signs, then we have to rule out a serious underlying pathology and look for the secondary cause of headache. But always remember, patient may fail to report all symptoms. So what are the red flag signs that we should see in a headache? If the patient is having the first or worst headache, if the patient has an abrupt onset headache, if there is progression of fundamental change in the pattern of headache, if the patient is presenting with a new headache after 50 years, or if the patient is presenting with a new headache with a background history of cancer, immunosuppression, or if the patient is pregnant, or headache associated with syncope or seizure, headache triggered by exertion, Valsalva maneuver or sex, neurological symptoms lasting for more than 1 hour, and abnormal general or neurological examination. So what are the indications for imaging? If the patient is having focal neurological signs or symptoms, onset of headache with exertion, cough or sexual activity, presence of an orbital bruit, onset of headache after age of 40 years, recent significant change in the pattern, frequency or severity of headaches, progressive worsening of headache despite appropriate therapy. Even when we see all this case, even when we investigate all these cases, 2% case alone will yield a treatable cause. Now coming to the treatment. In acute treatment of mild tension type headache, you can use aspirin, acetaminophen or NSAIDs. Always avoid opioids because there is always a risk for medication overuse headache. NSAIDs are actually superior to acetaminophen. Ibuprofen, naproxen and ketoprofen are the most studied ones, and tension type headache occurring in a migraine might respond to triptan. Now, risk of medication overuse headache. Avoiding medication overuse headache is an important goal, and for that always avoid opioids. Then when we give NSAIDs, it should be limited to less than 15 or fewer days per month. Triptans when used should be limited to 9 or fewer days per month. When the patient is presenting with chronic tension type headache, always remember to treat the comorbid stress, anxiety and depression. Simple analgesics are usually of little or no benefit. Coming to the non-pharmacological treatment, behavioral treatment for tension type headache includes biofeedback, relaxation, self-regulation of exercise, sleep, stress and other triggers, cognitive behavioral therapy and combination of the above therapies. Now, when do we ask the patient to undergo preventive treatment? When there is an increase in headache frequency or disability, or if the patient is diagnosed to have chronic tension type headache. The first line drug of choice for tension type headache is tricyclic antidepressants. Remember, SSRIs are not effective. Usually we give amitriptyline starting with a low dose, 10 mg, gradually increased to 50 to 150 mg per day. Benefit is only noted only after 4 to 6 weeks. Once that plateau is reached, we have to maintain it for at least 3 to 6 months before trying to tapering it off. Now, with amitriptyline, always be cautious about cardiac conduction defects, and also amitriptyline lowers seizure threshold. So, it is always prudent to take a baseline ECG before starting amitriptyline. Other side effects of amitriptyline include anticholinergic side effects, drowsiness, orthostatic hypotension, weight gain, and sexual dysfunction. Nortriptyline can also be tried. It is also started at 10 mg nightly, and the maximum dose is 100 mg. 10 to 25 mg increments on a weekly basis can be tried. It is mildly sedating, but the advantage is that the sedative effects are less and risk of weight gain are also less compared to amitriptyline. We can also try mirtazapine, 15 mg once daily at bedtime. and it can be increased to 30 milligram. Adverse effects include drowsiness, weight gain, and constipation. Venlafaxine can also be tried, and also gabapentin. Gabapentin is also started as 300 milligram OD, increased every 3 to 7 days. Maximum is 2,400 milligram, but we don't use that much high dose in clinical practice. And topiramate can also be tried, 25 milligram daily, and increase weekly by 25 milligram. Maximum is 100 milligram twice daily. Now, tizanidine is not commonly used. Other modalities of treatment, trigger point injection with lidocaine can be tried, Botox injections can be tried, neuromodulation using TENS, electromagnetic therapy, ultrasound and laser can be tried. Physical therapy can be tried using physiotherapy with exercises targeting neck and shoulder muscle tenderness, therapeutic heat and cold, massage, postural correction, spinal manipulation, traction, and or inactivation of muscle trigger points. Take-home messages. Remember that tension type headache is a relatively featureless headache. The increased pericranial muscle tenderness is the most important abnormal finding. Imaging is not indicated in tension type headache if the patient is having a stable headache of 6 months or more. Any red flag signs, go for imaging. Drug of choice is tricyclic antidepressants. Thank you.
Thank you for that simple presentation. Actually, this is a tough diagnosis when the patient comes in initially. So once they've done imaging and all and ruled out secondary causes and other primary headache syndromes, then it's easy for us. And usually this is unrewarding, the treatment. They usually respond to amitriptyline or nortriptyline, as you said. So, and I'd like to congratulate the neurology department for the Neurobites, the first session as it goes. Very nice terminology. So looking forward to more of such debates. And you want to add something?
Thank you, Archana, for an excellent presentation. And I also thank to the organizing team for giving an opportunity to chair this session. And Dr. Archana covered all the things in a crispy manner, and no more comments.
Yeah. Sharma sir can add on. Yeah. Ma'am also.
Archana, very good. Well done.
Thanks.
Okay. Now, keep it up. The thing is, I got a patient with chronic medication use headache. Just highlight on which are the drugs that are responsible for it. How will you tackle it? Patient is from Pune. Just tell me how to go about it.
Actually, it will be discussed later.
ഒരു അപ്രീസിയേഷൻ പറഞ്ഞോട്ടെ. അച്ഛനെ എനിക്കറിയത്തില്ല, പക്ഷേ ഞാനിങ്ങനെ ആഗ്രഹിച്ചു പോയി ഫിസിയോളജിയിൽ ഇങ്ങനെ ഒരാളുണ്ടായിരുന്നെങ്കിൽ സ്റ്റുഡൻസിന് ഇത്രയും ക്ലിയർ ആയിട്ട് ക്ലാസ് എടുക്കുന്ന, വളരെ സിമ്പിൾ ക്ലിയർ, ഒന്നും അറിയാതെ ഇവിടെ ഇരുന്നാലും എല്ലാം മനസ്സിലാവുന്ന രീതിയിലാണ്. അതിന് പ്രത്യേകിച്ച് ഒരു ട്രീറ്റ്മെൻറ്റിൽ 2% ട്രീറ്റ്മെൻറ്റ് ശരിയാ 2% പേഴ്സൺസേ ആവുന്നുള്ളൂ. ആൻഡ് ഇറ്റ് വാസ് എ സിമ്പിൾ പ്രസൻറ്റേഷൻ വിത്ത് ക്ലിയർ ഐഡിയാസ്. ആൻഡ് പ്രൊജക്റ്റ് ചെയ്തതും എല്ലാം വളരെ നന്നായിട്ട് മനസ്സിലായി. അപ്പോൾ ഞാൻ ആഗ്രഹിച്ചു യു ക്യാൻ ബി എ ഗുഡ് ടീച്ചർ, ബെസ്റ്റ് ടീച്ചർ എന്ന്. താങ്ക്സ് എ ലോട്ട്.
Thank you, ma'am, for the thought-provoking session, ma'am. Now I call upon the chairpersons to the dais to hand over the memento to our speaker, Dr. Archana M. I request the chairpersons to stay back on the dais. Now I call upon Dr. John K. John to hand over the memento to our chairpersons.
Thank you, everyone.
It's my honor to introduce the next speaker, Dr. Jerry A. George. Dr. Jerry began his medical journey from Government Medical College, Trivandrum, subsequently pursued MD from Lady Haring Medical College of Medical Science, Delhi. He received the prestigious Angela Vincent Award for the Best Young Neurologist Investigator at the World Congress of Neurology in 2023. His areas of interest encompass neuroimmunology, epilepsy, cognition, and neuromuscular diseases. Dr. Jerry will share insight on the topic, other lesser known primary headache.
Hello.
I invite you, sir. To chair the session, I welcome Professor Dr. Shahul Hamid, HOD, Department of General Medicine, Believers Church Medical College, Tiruvalla, and Professor Dr. Jency Maria Koshi, Department of General Medicine, Believers Church Medical College, Tiruvalla.
Thank you, Pooja. Good afternoon, everyone. Before just starting, I would say that I am honored because I can see so many veteran physicians, so many veteran people in the audience listening to me. I am probably one of the junior most consultants. So this is an honor. So am I audible? So I am dealing with a little bit of a topic usually uncovered, usually unheard, or lesser discussed. So that's why this terminology in the classification is actually other primary headaches. So that's why I had put the term as the lesser non-primary headaches. This is the outline. In the International Headache Society has classified the International Classification of Headache Disorders, the version 3 that came in 2018. Before that was the beta version in 2013. So these are the 10 headaches, primary headaches. Primary meaning headache in itself is a disease, is the problem. There's no secondary cause. So we will see one by one. This is mostly theory. So I have made it a case discussion based. Whichever cases I am discussing here are not my cases. These are already published from the literature. Because these cases are very rare, and probably many of these will go for case reports. And also one more thing, I will, whenever I say the primary headache, I have written the description by the ICSD classification, version 3. And this not better accounted for any other ICSD 3 diagnosis. You can see this frequently in all the diagnostic criteria. So it is written like that because it is a reminder always to consider other diagnoses that may better explain a headache. Actually, it is dangerous. I would say it is a little bit dangerous to diagnose these lesser headaches on the first contact because this in itself are very rare entities. Mostly there might be secondary causes. So we'll start with a description of a 53-year-old gentleman. He had multiple episodes of headaches lasting about 30 minutes, severity 8 out of 10. It was precipitated by cough and Valsalva maneuvers. The examination is normal. The imaging with MRI brain and MR venogram unremarkable. So what's the first thing that comes to our mind? This precipitated by coughing and Valsalva maneuvers, some raised ICP, some underlying pathology. So we will see what it is. And this is the second case, a 17-year-old girl with worsening headaches since 3 years. Paroxysmal debilitating midline headaches brief and associated with coughing, laughing, and neck extension. Examination unremarkable except impaired tandem gait. So there was an impaired tandem gait. Now, if you look at the MRI, the diagnosis is clear. We'll get back to this after the discussion. So the first one actually came out to be a primary headache. The second one is a mimic, a secondary cause. So the first one is primary cough headache. The terminology is primary. They have described it as it is precipitated by coughing or other Valsalva maneuver, but not by prolonged physical exercise in the absence of any intracranial disorder. As we said, in many of these diagnostic criteria, this will be the first line, at least 2 headache episodes. It is defined like that because the first episode, it is not easy to make the diagnosis. And it is brought on and occurring only in association with coughing, straining, or other Valsalva maneuver. It is sudden onset and it might last only even a 1 second and might be up to 2 hours. So, as we said, it is there, not better accounted for any of the ICSD-3 diagnosis. So, the peak almost comes immediately, then it subsides over a few seconds or minutes. I have put that symbol there because the classical saying was the 3 C's, a cough headache, cluster headache that already discussed, and coital headache. We'll come to that. 3 C's are more common in males, and the other ones usually it's female prominent. So this is the case that we saw as the second case. That was a Chiari type 1 malformation. If we go back, you can see that the cerebellar tonsils are descending downwards here. And the first one came out to be primary cough headache. So again, the importance of ruling out secondary causes before making this rare diagnosis. The mechanisms of these headaches are mostly unclear, most of them. And it is said that likely there is raised ICP. And as we said, imaging should be there to rule out secondary causes. And most of the spontaneous remit within 4 years. Indomethacin might be effective. Topiramate and acetazolamide also tried because there's a notion that there might be raised ICP. So we'll come to the next case. A 35-year-old gentleman, otherwise he is healthy. The headache is triggered by jogging sessions, usually around the peak of his exercise. It is associated with photophobia and some noise sensitivity and nausea, and relieved once he stops exercising. Examination is normal, MR imaging is also normal. So this is the second type of primary headache. This terminology is primary exercise headache. There's a broader terminology called primary exertional headache, which was used earlier. The cough headache, exercise headache, coital headache, all was grouped under. So now the terminology has been changed to this. And headache is preceded by any form of exercise in the absence of intracranial disorder. And again, the first and 1 and 4 lying constant there. And it is brought on by occurring only during or after strenuous physical exercise, not otherwise. And it should only last for less than 48 hours. Again, these are all definitions. Sometimes we might not get patients fitting into the definitions. Also, we should, in the first occurrence itself, we should rule out the dangerous conditions, SIH, dissection, RCVS, etc. So there is a study of headache epidemiology. It is known as the Vaga study. Vaga is a parish in Norway. So they selected, this was done by a solitary single neurologist, a large group of indigenous people, they are Vaga, they were selected. The reason they wrote, the reason for selecting them was because they practiced stoicism. So that is endurance of pain, and they denied medicines. So they could study the natural course of the diseases. The question was, I had put it here because a person who is having migraine or any other primary headache can also have another primary headache. So in that study, it was reported that exertionally 46% co-occurred with migraine. So as we already discussed, secondary etiology is very important to rule out this before making the diagnosis of exercise headache, subarachnoid hemorrhage, reversible cerebral vasoconstriction syndrome, dissection, IEH, and some already in a talk it was taught the cardiac cephalalgia and pheochromocytoma. So every time exercise someone gets this headache, we have to look at the heart also. The pathology is not very clear, but some studies have shown that the incompetent internal dural valves in the context of Valsalva maneuvers might cause the decrease in cerebral venous drainage, and that might cause these headaches. Indomethacin and beta blockers are tried. Again, it's common to all these primary headaches. There are no clear guidelines for treatment. These are all just based on anecdotal evidences. So next one again, I told you, earlier known as coital headache. So it's now the terminology is primary headache associated with sexual activity. Again, more common in males. So it starts as a dull bilateral ache, and with sexual excitement increases, and suddenly it becomes intense at orgasm in the absence of any intracranial disorder. So it is brought out only during sexual activity, and it is increasing in intensity with the excitement. So again, case 4, see, it was precipitated by the 40-year-old gentleman whose severe headache, which was precipitated by sexual activity. The examination was essentially normal, but look at the CT scan. The CT scan shows a clear-cut subarachnoid hemorrhage. So it is the literature says that 4 to 12% of these aneurysmal ruptures, they say that some sexual activity provoked the SAH. That's a literature called 4 to 12%. So it is mandatory, the ICSD-3 classification says it is mandatory to exclude SAH. So usually we don't see that, that wording mandatory in guidelines, but here they have said it is mandatory to exclude SAH, dissection and RCVS before making this diagnosis. And as a rule, if during sexual activities, if multiple explosive headaches occur, unless proved otherwise, it is to be considered as RCVS. So that's what they have told. The pathogenesis is unknown. Again, triptans, topiramate, propranolol, indomethacin, multiple drugs are tried, but there are no clear guidelines. So we will not focus much on this thunderclap headache because I'll tell the reason in next slide. This thunderclap headache in itself warrants extensive evaluation before making a diagnosis. So making a diagnosis of primary thunderclap itself is dangerous. So we have to be very cautious before making this diagnosis. So it is abrupt onset and the maximum intensity reaches within less than 1 minute, and it lasts for more than or equal to 5 minutes. The reason they have written, it should be the diagnosis of last resort. So in itself, there is less evidence that it exists as a primary headache disorder. Always rule out other causes, imaging, other tests, blood investigations, CSF, everything. So we have a 20-year-old university student who have had 1-year history of persistent headache triggered by environmental cold exposure. So intensity is proportionate to both time spent and magnitude of the cold environment. No associated nausea, vomiting or photophobia, no autonomic symptoms. And she was prescribed naproxen 30 minutes before the cold because she was living in a country which is inherently cold. Avoiding the trigger was not an option. So they tried indomethacin and they have written it was effective. So the next one is called stimulus headache. So it can happen with either external application of cold or ingestion or inhalation of cold substances. Earlier that entity was called ice cream headache. So, and brain freeze headache. So many terminology were there. So they have grouped it into one. So this is the criteria. Again, they have written only during application. That is the criteria. Otherwise, there is no headache. And also it resolves 30 minutes after the removal of cold stimulus. If it is ingestion or inhalation, Immediately after the cold stimulus touches the palate or posterior pharyngeal, headache can happen. And it should resolve 10 minutes after the removal of cold stimulus. That's how it is defined. The headache is usually frontal or temporal, and most commonly it is bilateral, sharp, intense, and stabbing. Mechanism is unclear. It is said that the direct stimulation of cold receptors are the one of, or vascular changes are proposed. So actually, if at all we make a diagnosis of this, usually it will not require treatment because you just remove the trigger and it will go away in 30 minutes. So another interesting case, a young fighter pilot who's aged 29 years, he was flying a MiG. So he has a headache for 1.5 years. So it was limiting his ability to fly. So he was diagnosed as having migraine. He was given valproate. No, nothing is working. They had to limit his time of flying. And it was usually right-sided, but occasionally on the left also. And it lasted 2 to 3 days. And it appeared late in the afternoons and appeared to be precipitated work-related stress, including flying. Nothing else in the investigation, examination normal, imaging normal, nothing else. And after extensively taking a history, they found out that it was an ill-fitting helmet. The helmet he was wearing, and after introducing a well-fitting proper helmet, the complete headache was gone. So that's our next external pressure headache. They have classified as a primary headache syndrome. It's due to external compression or external traction. Both can cause headache. So external compression headache resulting from sustained compression of pericranial soft tissues, like a tight band, hat, helmet, goggles worn. So sometimes we miss these things. The patient might be using, maybe a worker, like in construction worker, he might be using a heavy helmet. So if we miss this in history, then we will go on investigating and we will not reach anywhere. So it is defined as brought on occurring with 1 hour during the sustained external compression, and it should resolve 1 hour after the external compression is relieved. This is external traction, looks something similar, and just it should be a sustained external traction on the scalp without causing damage to the scalp. That's also. So pharmacology treatment is rarely needed. Obviously, if we can find a trigger, we will just take it out. So another one, this primary stabbing headache, sometimes patients come to us and say, the small sharp pain which goes away. So we have to just differentiate from the other tags, trigeminal autonomic cephalalgias, trigeminal neuralgia or other neuralgias, because it might look like something, but there should be no cranial autonomic symptoms. And it can last a few seconds. And the primary stabbing headache involves extra-trigeminal regions usually in 70% of cases. And it may move from one area to another also. So we might even think it's functional or. So it's described as sharp needle-like stabbing, jabbing, and non-pulsatile. And many treatments tried indomethacin, coxibs, nifedipine, melatonin, gabapentin are tried. But there's no guideline for this. And this is the unpredictable alternation between symptomatic and non-symptomatic characteristic trait for these headaches. A 58 years old lady with moderate persistent pain in the vertex nearby right parietal scalp. The area is fixed and defined borders. The area is she defines that it is an ellipsoid shape and a 5 to 6 centimeter diameter area. The neurological examination was undergone apart from allodynia in the site, an area of coin-like area where there's allodynia. So, the workup examination, MRI, everything is normal. So that is called a nummular headache. It's another type of primary headache. So I had put a coin because it was already called a coin-shaped headache, coin headache, because it is an area of ellipsoid area looking like a coin. And the one difference is that the other ones we were not getting anything in the examination. But in this one, that ellipsoid area will have hyperesthesias and allodynia. So that's the difference. We will get something in the examination there. So it is highly variable duration, and it is continuous or intermittent. It is sharply contoured, fixed in size, elliptical, and it is usually 1 to 6 centimeter in diameter. So this I have already told, and just the parietal area is the most common location for nummular headaches. And NSAIDs, gabapentinoids, and tricyclic antidepressants have been tried. Say a 70-year-old gentleman complains of headache during sleep at night for the past 1 year. The headache starts after he falls asleep. And due to headache, he wakes up from sleep around 3-4 am and almost every night, and his headache persists. Then he cannot sleep. He will keep himself busy with religious activity, and headache gradually resolves. So examination, imaging, everything is normal. Again, always we have to look for secondary causes. The headache that is waking up a patient from sleep always to be considered as dangerous. We have to work up for secondary causes. This is also like a last diagnosis of exclusion. We cannot diagnose this at the first go. So it occurs only during sleep, and it cannot be attributed to other pathology, lasting 15 minutes to 4 hours. So we have to exclude sleep apnea. Even though in the definition they have told people with sleep apnea can sometimes get this secondary hypnic headache. It is not mandatory to exclude sleep apnea, but we have to work up for nocturnal hypertension, hypoglycemia, medication overuse, other intracranial pathologies, everything. They have tried lithium, caffeine, melatonin, and indomethacin. So now, because involvement of hypothalamic structures have been defined, and studies have shown that the MRI brain may also show the reduction in gray matter in hypothalamus in this. Suprachiasmatic nucleus might be involved. So I think it's the last case. A 44-year-old lady, she remembers the exact date when her headache started. It started on July 14, 2015. She can say that with no pain-free days, without triggering factors. She had no history of headaches before this. And her headaches was 7/10, and with 2 peaks of 10/10 per week. It was pulsatile, but nausea, phonophobia, no pain-free hours during the day. All investigations within normal limits. So this is the 10th type of headache. It is called a new daily persistent headache. So daily, from its onset, it is daily. And what it can look like migraine, it can look.
Today's session. So my topic, I will be talking about secondary headaches and red flags. So secondary headache means the headache is or can be attributed to some alternate etiology. Unlike a primary headache where the headache itself is the disease. So in population-based studies, the incidence and prevalence of secondary headache is comparatively less. The data is variable, but somewhere between 10 to 20% is the estimated prevalence. ICSD-3 has given almost 8 categories for this secondary headache and 46 subcategories in each of them. The Akershus study was done in Norway, where they have examined 1 year prevalence of chronic secondary headache. And they found that it was 2.1%, which is relatively low. And majority of them have a relatively benign secondary headache, that is a medication overuse headache. So we can tell that as age advances, the prevalence of primary headache decreases and the prevalence of secondary headache increases. Similarly, in elderly people, secondary headaches are common, and any headache or a new onset headache needs thorough and meticulous evaluation. So this has been already mentioned, the pain sensitive structures in the head, in the extracranial compartment, the eyes, ears, scalp, paranasal sinuses, teeth and temporomandibular joints, the cranial nerves, 5th, 9th and 10th cranial nerves, the intracranial structures, predominantly the proximal dural arteries, large Willisian circle arteries, dural venous sinuses, pachymeninges. The pyometer is not pain sensitive. So we should think about all these structures while dealing with the headache, and we should try to ascribe whether the headache can be localized to any of these anatomical substrates. Coming to the ICSD-3 classification, I will be talking in detail about each of these. There are 8 categories in the ICSD-3 classification for secondary headache. The headache attributed to trauma or injury to the head and or neck, cranial and or cervical vascular disorder, non-vascular intracranial disorder, substance use or its withdrawal, infections, disorder of homeostasis, headache or facial pain attributed to craniofacial structures, anatomical structures, headache attributed to psychiatric disorder or a primary psychiatric illness. So these 8 categories. So first we will deal with headache attributed to trauma or injury to the head and or neck. Post-traumatic headache can be due to a minor head trauma, major head trauma, whiplash injury or post-craniotomy, like surgery, post-surgical headache. The headache should start within 7 days after the head trauma, or after regaining consciousness following a head trauma, or after discontinuation of medications which impair the patient's ability to report or sense the headache following a trauma. The common risk factors for a persistent post-traumatic headache include a prior history of a primary headache disorder, mild head trauma at presentation, and younger age. So these are the risk factors for a post-traumatic headache. It is relatively common. The phenotypic peculiarity of this post-traumatic headache is most of these patients have a phenotypic similarity with migraine. And the pathophysiology also points towards migraine than tension type headache. Both migraine and tension type headache features can be seen in post-traumatic headache, but overall it is leaning towards a migraine phenotype. So the treatment also may be focused more on migraine. So the acute post-traumatic headache is there which occurs less than 3 months from the trauma, and it can be persistent, which is more than 3 months from the trauma. Why this classification is when a patient is having an acute post-traumatic headache, that is a red flag, which I will be dealing, which I will be telling, and chronic post-traumatic headache is considered as an orange flag. The second categorization, headache attributed to cranial and or cervical vascular disorder. The first question, we always think whether an ischemic stroke can produce headache. Usually, in general, ischemic strokes won't produce headache unless the patient had thrombolysis and developing sudden onset headache, which means there is a hemorrhagic transformation or a hematoma. Second, posterior fossa strokes, especially midbrain strokes, cerebellar strokes, which may produce mild mass effect and raised ICP, can produce headache. Otherwise, minor strokes and most of the larger strokes won't produce headache unless there is a mass effect or hemorrhagic transformation. But one thing is important, a past history of migraine is very important in cases of young stroke that has been told previously. Second, non-traumatic intracranial hemorrhage. So the two major things, one is the subarachnoid hemorrhage and other is the subdural hemorrhage. The subarachnoid hemorrhage usually presents with a thunderclap headache. What does a thunderclap headache means? It is the worst headache in one's life, which has an abrupt onset and it reaches a peak or nadir within 1 minute. So the onset to the peak time is usually less than 1 minute. That is called a thunderclap headache. But we have to remember that in 50% of patients with a subarachnoid hemorrhage, thunderclap headache may not be present. And such patients will present with a mild headache and there will be a sentinel bleed, something called as a sentinel bleed in the CT, very minimal bleed which may not be even picked up in the CT. And these patients will have a sudden worsening within 24 to 48 hours to go for a catastrophic subarachnoid hemorrhage. Similarly, subdural hematoma. Subdural hematoma, the headache usually happens due to midline shift and mass effect. And when this happens, there will be stretching of the meninges and that will produce acute headache. The third, before going to vascular malformation, lobar hemorrhages, the intracerebral bleed, hypertensive bleeds are unlikely to produce except it is in cerebellum or in the posterior fossa. Lobar bleeds can produce headache, usually due to underlying cerebral amyloid angiopathy. Vascular malformations are another important causes. Saccular aneurysms like a PICO aneurysm, which has an additional clinical feature of third nerve palsy, or an ACO aneurysm, which can present with transient bilateral lower limb weakness and abulia. AV malformations, dural AV fistulas, cavernomas, and leptomeningeal angiomatosis, or the so-called Sturge-Weber syndrome, all these can present as migraine type of headache. Now coming to arteritis or the inflammation of vessels, the three classical type of patterns of the arteritis occurring in brain. One is the Jane cell arteritis, usually occurring in the elderly people more than 60 years age, presenting with a background of continuous stabbing temporal headache with recurrent bouts of severe episodes of headache. And the patient can have additional systemic symptoms. In addition to headache, he may have systemic symptoms and there will be raised inflammatory markers like ESR and CRP. If untreated, can proceed to catastrophic blindness and permanent disability. So Jane cell arteritis is very important and the patients usually will have a scalp tenderness and the corresponding investigations like temporal artery Doppler and the inflammatory markers will be positive. The second is the primary CNS vasculitis or the primary CNS angiitis. This means there is an inflammation of medium and small sized vessels in the brain, usually idiopathic. The patient will have presentation of a chronic headache, insidious onset, slowly progressive chronic dull aching type of headache. Along with that, the patient will have cognitive impairment. The patient will develop multiple territory strokes. So an old-aged person with recurrent episodes of stroke in multiple territories, after the classical stroke evaluation, we have to suspect of this thing, especially in the background of cognitive impairment and chronic headache. So primary CNS angiitis affecting medium and small-sized vessels. The next is a secondary CNS vasculitis. This can be due to chronic inflammatory or autoimmune conditions like systemic autoimmune conditions like an APLS syndrome or ANA positivity, SLE, or it could be due to secondary vasculitis following an infections like varicella zoster, which can preferentially involve the middle cerebral artery M1 region. So primary vasculitis, secondary vasculitis, and Jane cell arteritis, very important causes of secondary headache. Next, certain arterial disorders like carotid or vertebral artery dissections. these are very important causes of lateralized neck pain or head pain. Carotid artery dissection usually happens in the extracranial segment of the internal carotid artery. And the patients, around maybe 50 to 75% of patients will have a neck pain at the onset. Along with the pain, the patient can have other symptoms like visual symptoms, the manifestations of the ischemia itself, maybe presenting with a weakness or a TIA-like symptom, amaurosis fugax, anything can happen. But high index of suspicion, especially after a trauma, after massaging, such situations can produce this dissection. Vertebral artery dissection is slightly more common, happening in the extracranial segment of the vertebral artery where it pierces the dura. That is the V2, V3 junction, and this produces a posterior neck pain in the occipital region. Then post carotid artery stenting and endarterectomy, this can also produce similar type of pain. Why such neck pain or headache happens in this vessel wall pathologies? When there is a sudden tearing or manipulation of the vascular wall, there will be sudden release of these cytokines, and that is actually producing headache. So this sort of pains will be responsive to NSAIDs. Venous disorder, we know, cortical vein thrombosis or a cerebral venous sinus thrombosis can produce headache in majority of the patients. 90% of patients will present with headache, but in addition, they have other symptoms of raised ICP and background of clinical contexts like puerperium, anemia, all those can happen. Venous stenting can also produce headache. Then the next, vascular pathology producing thunderclap headache. Already mentioned, the reversible cerebral vasoconstriction syndrome or the posterior reversible encephalopathy syndrome. That everything is a spectrum which is happening because of the autonomic dysregulation of the vascular tone and produces abnormal constriction and dilatation. Usually, these sorts of conditions are precipitated by severe exertion, sexual intercourse, accelerated hypertension. In the background of accelerated hypertension, the patients will present with severe thunderclap headache, which remits after maybe few hours, and again it recurs. The clinical symptomatology usually lasts up to 1 month, but headaches can persist up to 1 year in these conditions. Another important thing is radiological resolution of the multifocal vascular narrowing usually resolves within 3 months in these sort of conditions. These are relatively benign but difficult to treat. The usual agents which are used to treat are calcium channel blockers like nifedipine and verapamil. So RCVS is a very important condition, and there should be radiological phenomenon happening. The radiological resolution should happen within 3 months. Otherwise, we have to go for other causes like primary angiitis of CNS, which is a more progressive disorder. Then chronic vasculopathies like cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy, CADASIL, genetic autosomal dominant disorder, MELAS, mitochondrial disorder, then certain particular vasculopathies like moya, which affect the terminal ICA, M1MC and A1ACA, and cerebral amyloid angiopathy, degenerative diseases like amyloid angiopathy. These all can produce headache. Pituitary apoplexy is something which should be considered in a lady, in a postpartum lady with sudden headache and raised ICP features. Also should be considered in the background of a snake bite, such scenarios. Pituitary apoplexy also always should be considered in a young patients with sudden raised ICP features and visual disturbances. So this MRI, TOF MR angiogram, I have just kept to show this dissection. The internal carotid artery, the extracranial segment is showing a false lumen, which may be better appreciated in a CT angiogram. The next category is headache attributed to non-vascular intracranial disorder. This could be due to raised CSF pressure or due to low CSF pressure. Raised CSF pressure, the idiopathic intracranial hypertension. Then this intracranial hypertension could be secondary due to hydrocephalus, could be due to metabolic, toxic or other hormonal factors. Low CSF pressure could be due to, the classical scenario is the post-dural puncture headache, which is due to a transient leakage. Spontaneous intracranial hypotension is a progressive syndrome where there is a positional headache. The patient will have worsening of the headache on lying down. in idiopathic intracranial hypertension and exacerbation of the headache on assuming an orthostatic position. That is called as spontaneous intracranial hypotension with a positional headache. This MRI just wanted to show the various features in idiopathic intracranial hypertension. You can clearly see this is the optic nerve. There is a kinking of the optic nerve. Perioptic nerve sheath widening is there, subarachnoid space. Then there is a partial empty sella, right transverse sinus stenosis. And here you can see the widened subarachnoid spaces, the white color around the optic nerve sheath. And there is a flattening of the posterior sclera. Okay. The non-infectious inflammatory causes like neurosarcoidosis, aseptic meningitis, lymphocytic hypophysitis, Handel syndrome, intracranial neoplasia. Often people will ask and come and ask us to do an MRI because they suspect a brain tumor that can produce headache but not very common. Intracranial neoplasm and carcinomatous meningitis and metastasis, especially in the background of breast or malignant melanoma, breast malignancy or malignant melanoma. Intrathecal injections, usually methotrexate. Epilepsy is very important cause of headache, and ictal epileptic headache and postictal headache can happen. Both of these occur in the background of a posterior head region, that's a parieto-occipital lesion producing epilepsy. Similarly, Chiari malformation type 1, as Dr. Jerry mentioned, this is an important cause of positional headache and a secondary cuff headache. We have seen the primary cuff headache, but this is a cause of secondary cuff headache. Headache attributed to substance or its withdrawal. The exposure to certain substances, especially certain medications, alcohol, cocaine, anything can produce headache. Substance withdrawal, usually caffeine, opioids, estrogens, sometimes the chronic cannabis use and all, withdrawal will produce headache. The another important category is the medication overuse headache. Usually happens with the excessive use of ergots, triptans, non-opioids, opioids, and combination analgesics. So this is a very important condition which we encounter in the OPD. We should be very careful while prescribing medications for a migraine patient. And the use of over-the-counter medications always makes the patient use these medicines frequently, and the culminates in a medication overuse headache. The interaction between a therapeutic agent which is used abnormally and excessively, and when this is used in a susceptible patient will produce such a headache. So those patients with a primary headache diagnosis, mostly they have a migraine or TTH before developing this sort of medication overuse headache. This is like a chronic new onset daily persistent headache, and it's a significant risk factor for developing a chronic daily headache. So the diagnostic criteria, same like the other headache syndromes, headache occurring more than or equal to 15 days per month for minimum 3 months. What is important is the regular overuse for at least 3 months of one or more medicines, usually taken for the acute treatment of migraine or any primary headache. Ergotamine, triptans, opioids or combination analgesics on more than 10 days per month, or simple analgesics like an acetaminophen, paracetamol for more than 15 days per month, or any combination of the multiple drugs without overuse of a single drug, combination medications, usually for more than 10 days per month, or any combination of drugs for more than 10 days per month. But the problem is this combination pattern patients may not be able to tell. Usually they will tell that we will take all these medications, ergotamine, propranolol, anything. Some people will take Civelium for or flunarizine for acute exacerbation of migraine. So such erratic and haphazard medication intake will produce this sort of syndrome. So the American Migraine Prevalence and Prevention Study showed that these are the criteria for minimum duration for which these medications will produce medication overuse headache. So the most important thing is acute migraine treatment should be limited to 2 or fewer days per week, and opioids should be preferably avoided. About the treatment, so it consists of combining prophylaxis. We should start with the newer medicines and the 100% weaning of the overused acute medications. We should stop those medicines completely, and the provision of new acute medications. Suppose the patient is using naproxen, we can use ergotamine, similarly the vice versa. So this medication use should be limited to 2 or fewer days per week. And withdrawing the overused medication may result in significant improvement of headache in 2 months in around 50% of patients. So that again, it is suggestive of a medication overuse headache. Headache attributed to infection, nothing to tell more. Intracranial infections and systemic infections, sepsis. Headache attributed to disorder of homeostasis, hypoxia or hypercapnia, aeroplane travel, diving. Sleep apnea is another important secondary cause of headache. Post-dialysis, some patients may develop headache due to toxins. Arterial hypertension, another important cause, whether an accelerated hypertension can produce headache or not. The eclampsia, these all conditions should be excluded, but generally hypertensive urgency or an accelerated hypertension can produce headache when other causes are excluded. Hypothyroidism rarely can cause, fasting can cause, cardiac cephalalgia. The migraine-like headache, usually it is a migraine type of headache that usually, but not always, is precipitated by exertion. Usually occurs during an episode of myocardial ischemia. It can be a thunderclap type of headache, it can be a migraine type of headache. But the most important thing is such a headache will be relieved by nitroglycerin or revascularization. Nearly a third of those patients presented with headache as their sole manifestation in myocardial ischemia. Photophobia and phonophobia will be generally rare. Next is the craniofacial anatomical substrates producing headaches. I just want to tell a few words regarding cervicogenic headache. The terminology, the headache or the neck pain which is attributed to structures or the cervical vertebra, that is called cervicogenic headache. The commonest site of origin is the C1, C2 or the C2, C3 zygapophacial joints. So that is called cervicogenic headache. Then other are the secondary causes, especially ENT causes, paranasal sinuses, teeth, temporomandibular joint disorder. That is another important thing, but it can be easily diagnosed. Subacute angle closure glaucoma, due to recurrent episodes of obstruction to the aqueous flow, can lead to a gradual optic neuropathy and visual loss. Presents with a mild to moderate pain with visual blurring, which occurs in the dim light. There will be rainbow-colored halos, but the distinction from migraine is very important. Migraine, usually the halos occur before the pain. Here, the visual halos occur at the pain ictus. It can present as headache as the only sole manifestations during the raised intraocular pressure times and can be a migraine type of headache or a bilateral headache, which may be non-pulsatile with or without photophobia. The duration also can simulate a migraine and needs further investigations like slit lamp and gonioscopy. Headache attributed to psychiatric disorder, somatization, psychotic disorder, depression, separation anxiety, panic disorder, specific phobias, social anxiety or phobia, generalized anxiety disorder, post-traumatic stress disorder. The painful lesions of the cranial nerves and other facial pains, these are the characteristic syndromes where some cranial nerves are affected. The fifth nerve, like trigeminal neuralgia, zoster, herpes zoster can affect post-herpetic neuralgia. Similarly, ninth nerve, the glossopharyngeal neuralgia, stylalgia, the nervus intermedius or the nerve of Frisberg can produce compressive neuropathy. Similarly, occipital neuropathy, the cause of neck pain. Neck-tongue syndrome is a very interesting syndrome which happens due to the impingement of the C1, C2 nerve roots and will usually produce severe unilateral neck pain and hemiglossal dysesthesias. On turning the head to one side, he will develop neck pain and reduce the sensation in the tongue. Very interesting syndrome due to impingement of the C1, C2 nerve roots. Crowned-Dent syndrome, exactly it will mimic meningitis, but this is due to deposition of calcium pyrophosphate crystals. 5 minutes. Calcium pyrophosphate crystals in the cruciform ligament surrounding the atlantoaxial joint. So painful optic neuritis, headache attributed to ischemic ocular motor nerve, Tolosa Hunt, another paratrigeminal Reeder's syndrome, recurrent painful ophthalmoplegic, burning mouth syndrome, something is which is very benign happening in young to middle-aged females. So the general diagnostic criteria, as we have already mentioned, the most important thing in a secondary headache, the temporality of the headache has to be relied upon heavily. Temporality is very important in case of secondary headache. Headache has significantly worsened in parallel with the worsening of the presumed causative disorder, or it has significantly improved in parallel with improvement of the presumed causative disorder. The second point, and these 2 points are very important. The diagnostic criteria no longer require the remission or substantial improvement of the underlying disorder before the diagnosis can be made. Similarly, both these patterns can present in a single patient, the primary headache and secondary headache. These are more for the research purposes. The headache can be coded as a secondary headache attributed to causative disorder when it is occurring in close temporal relation to another disorder which causes headache. And similarly, when pre-existing primary headache becomes chronic, or it is increasing in frequency or severity in close temporal relation to a causative etiology, then both these diagnoses should be made. Now, I will briefly tell about the red flags and orange flags. The definition, red flags, these are the symptoms or other information that encourage testing or observation of the patient. Orange flag means symptoms or information that is only alarming when it occurs with other orange flags or red flags. What is the need? Many possible laboratory tests for a suspected secondary headache are there. These are available, but running a battery of tests like laboratory investigations and imaging, sometimes nothing will come up, and there may be accidental reports, like sometimes the patient will develop a meningioma and everything will be attributed to such an incidental finding. So it is not possible to detect every secondary headache with a standard neuroimaging or laboratory test. This is an important paper published in 2010, and what they have found is they subjected all the patients with a headache to an MRI imaging over a time period, and they found that only 2.1% of the MRI of those imaged were significantly abnormal. Significant abnormalities in those suspected to have an intracranial abnormality was 5.5%. So 2003, the mnemonic SNOOP was proposed. Now they have updated it. This is a SNOOP 10 list, but I am telling 12 things. This is a red flag and orange flag. Why there is an orange flag is when fever alone is occurring, that is an orange flag, but systemic symptoms including fever, when it happens, it's a red flag. Neoplasm, neurological deficit or dysfunction, then onset of the headache, older age, pattern change, all these are red flags. Positional headache, I have already mentioned. Precipitation of the headache, papilledema, very important thing, especially in the background of IH. But 5% of IH patients can present without papilledema, IH without papilledema. Progressive symptoms, pregnancy puerperium, painful conditions. These are the secondary causes of cluster headache. Jovan sir has already mentioned carotid artery thrombus, CVT, dissection, pituitary tumors, meningiomas, nasopharyngeal carcinoma, sinusitis, orbital pseudotumor. These conditions can mimic a cluster headache or maybe produce a secondary cluster. Post-traumatic headache, the P symptoms, I have told you the duration of the traumatic pain is important. Orange flag means chronic PTH. Pathology, painkiller overuse. Two additions are there after the COVID outbreak. There's a post-COVID headache syndrome. Usually occurs in the background of migraine as a chronification or new onset daily persistent headache following a long post-COVID syndrome. Post-vaccinations, especially in the background of COVID vaccine or any other vaccine, can produce venous sinus thrombosis or even without any vascular event. What are the green flags? These are not validated, just a guide. Whether the present headache was present during childhood. The headache is temporally related to menstrual cycle. The patient has headache-free days in between. Family members have a similar phenotype. Headache occurred or stopped more than 1 week ago. These all things can this may suggest that the patient may have a benign headache. This flowchart we will skip. My take-home messages would be a meticulous history and examination and a high index of suspicion are very important. Running a battery of tests may not be appropriate. Secondary headaches can manifest like primary ones. That is another important thing. All the primary headaches, migraine, TTH, even hemicrania continua or paroxysmal hemicrania where a posterior hypothalamus is involved, a structural lesion impinging on the posterior hypothalamus can produce paroxysmal hemicrania like headache. But even after the surgical removal of the lesion, such a headache may not produce complete remission, and sometimes the response to medications like indomethacin is comparatively low in comparison with a primary paroxysmal hemicrania. So secondary headaches can manifest like primary ones. Caution should be taken in the elderly people to avoid permanent disability like visual blurring or permanent vision loss. Contrast imaging and vascular imaging. MRI with contrast and vascular imaging, especially TOF, time of flight MR angiogram, are very, very important and should be given due importance. Thank you.
Excellent talk, Dr. Hari Krishnan. In such a short time, you covered so many different conditions. And that is what I was thinking. It's how many things we need to keep in mind that you don't miss, because here missing will be the big problem. And yeah, it obviously requires a multidisciplinary approach also. And a useful tip that you gave to probably start thinking is those flags.
The anatomical localization is very important. When a patient is coming with headache, always think about the potential structures which can produce. Then we can stepwise eliminate most of these things.
Thank you, Dr. Hari Krishnan, for the exhaustive and very comprehensive talk and the lucid manner in which you put the whole topic of secondary headaches and also the red flags that we have to always consider. You always, headaches as to us as physicians, as earlier alluded to, have always been a diagnostic dilemma. And given the numerous conditions and the various causes of the headaches, it always is essential, as told earlier by Dr. Jansi, that a good history examination is essential, besides looking into the subtle clinical localizing signs that may give you a telltale clue, especially where the cervical dissections, and having a great deal of suspicion about any of these entities is always very essential, that enables a physician to look into the causes and also clinch a diagnosis. These are very essential elements: a good history, a clinical examination, as well as looking into the signs. You had also put in a very interesting topic about, I think Dr. Sharma had wanted to ask you a few questions about analgesic headaches. I think, sir, would you like to ask questions on that?
Yes, few questions and doubt. Ischemic stroke involved in the midbrain and cerebellum will produce pain. Cerebellum, I can understand some edema and all that.
Not always, sir. Midbrain also there may be some sensory central neuropathic pain scan.
But pons will not produce, medulla will not produce. Is it like that?
Sir, pons and medulla, these are very watertight compartments. Even a mild edema, when we generally tell it's a lacunar stroke itself, that will produce some sort of edema and the stretching of the adjacent vasculature. So that may produce mild headache. Such posterior fossa tumors, posterior fossa strokes will usually produce milder headaches.
Okay.
Unless there is a decompensation.
No, you sorted out midbrain. That's
yes, sir. Midbrain can also
That is the answer for this. How do you identify sentinel bleed?
Sentinel bleed is very difficult to identify, sir. An early CT may sometimes miss. Only thing, we should have a very high index of suspicion. Very difficult. And patient will worsen in a catastrophic manner.
Then you said about GC, tenderness. I had GC. Gensel arthritis. I had two patients last year. One patient, both from Ernakulam, and came and patient was running fever, headache, MRI negative, usual picture. So initially, by head-to-foot examination I did, intuition was it is temporal arthritis. I looked for tenderness, pulsation, everything was normal. So I just repeat the thing, come after 2 weeks, but I started on little steroid because it is risky. After that, by the time it is related to one of the neurosurgeons, came to me back. At that time, the left-sided pulse became totally absent and it was extremely tender. So you need not always suspect it. But other clues will be you will have a CRP elevation, Sometimes you can have alkaline phosphatase elevation, pneumochromocytic anemia, all these things, weight loss. These are the
Systemic
clues.
symptoms will be there, sir.
Yeah.
One more thing, sir, even with a biopsy, we may miss it because adequate length of biopsy is important. Otherwise, skip lesions will come, and if we biopsy a small segment with a skip lesion, it will be
Not
missed.
only that, 5 centimeter you have to take,
Yes, sir.
it can be segmental.
Segmental.
So I sent to Amrita and got it done. It was done. Then next thing is another clue for carotid dissection will be
Hornets. Hornets will be there, and even it can mimic a cluster type phenomenology.
Yeah, right. Another thing is intracranial hypotension produces a pachymeningeal enhancer mechanism.
Yes, sir. Bilateral diffuse, very
Mechanism, I don't know.
that is produced because of the sagging of the whole brain downwards, sir, and will produce an increased permeability of the blood-brain barrier because of the traction of this blood-brain barrier meningeal
That is the reason.
vasculature, and will produce diffuse. It is not like the other contrast enhancement, very smooth and diffuse. The entire frontotemporoparietal convexity will be enhanced.
No, I've seen the photos, but only thing is mechanism I didn't know. The thing is, you said about structures outside the head. Headache is not due to brain alone. So one patient was admitted by the PGs and MO as stroke. This is a patient, walkie-talkie patient, no focal deficit patient. When I came for a round, the patient had gone to the toilet, came back walking. Clinical examination showed bilateral angle crushochroma. Bilateral angle crushochroma acutely is unusual, but the patient had steamy cornea, vertically oval people not reacting, and small AC. So that, and circumcorneal cranium, that is easy. But proper examination, proper history, everything is important.
Usually pupils will be sluggish in such cases.
Yeah, sluggish and vertically oval. This is a usual thing. Anyway, thank you. This is a nice presentation. Thank you.
Thanks. Thank you.
ഞാനിപ്പോൾ ഈ ഏജിൽ ഇപ്പോൾ ഒരു 110 പറഞ്ഞപ്പോൾ അതിലൊരു 5 തിങ്സ് തലയിലുണ്ടെന്ന് തോന്നുന്നു. കുറേ നെയിംസ് ഒക്കെ പറഞ്ഞു. ഐ വാസ് സോ ഹാപ്പി. ജെറി ഓൾസോ. ജെറി ഈസ് മൈ നെക്സ്റ്റ് ഡോർ റൂംമേറ്റ്.
Everything is based on whatever you have taught me.
ആൻഡ് ഐ ആം സോ ഹാപ്പി ദാറ്റ് ഐ എം ഒരു ചെറിയൊരാളാണ് ഫിസിയോളജിയിലൊക്കെ. പക്ഷേ സർമ്മ സാറ് കോട്ടയം മെഡിക്കൽ കോളേജിൽ വന്നത് ഇറ്റ് ഈസ് എ ഗിഫ്റ്റഡ് തിങ്. ഞങ്ങൾക്ക് നല്ല സാറുമാരായിരുന്നു, മാത്യു സാർ ആൻഡ് സർമ്മ സാർ. ഇപ്പോഴും ഇങ്ങനെ ഓരോന്നൊക്കെ ചോദിക്കുമ്പോൾ ഞാൻ പറഞ്ഞു എൻ്റെ തലയ്ക്കകത്തൊന്നും ഇല്ല എന്ന് തോന്നും. ആൻഡ് ഇറ്റ് വാസ് ഒരു കാര്യം പറഞ്ഞോട്ടെ, ഐ വാസ് ലിസ്ണിങ്. ഇപ്പോൾ ഞാൻ പോകേണ്ട സമയമൊക്കെ കഴിഞ്ഞു. ജെറിയുടെ ടോക്കിലും സെക്കൻഡറീസിന് ഇമ്പോർട്ടൻസ് ഉണ്ടായി. മാഡം പറഞ്ഞു, ജിൻസി മാഡം പറഞ്ഞു, that is what is lacking in this third generation. We are all, 3 generation പറഞ്ഞാൽ സർമ്മ സാർ ആൻഡ് ഐ ഫസ്റ്റ് ജനറേഷൻ. ഓൾ ദി സ്റ്റുഡൻസ് ടെക്നിക്കൽ ഇംപ്രൂവ്മെൻറ്റ് കൂടെ. ബട്ട് ഹിസ്റ്ററി ടേക്കിംഗ് വിത്ത് സിമ്പിൾ പൾസ്, ഡോക്ടർ പൈസർ, he didn't teach me, I heard only. With that he can go over a diagnosis. ഞാൻ വളരെ അനിൽ വിളിക്കാതാണെങ്കിലും ഞാൻ വന്നേനെ. ഇപ്പോൾ ഒത്തിരി കാര്യങ്ങളുണ്ടായിരുന്നു, കാറ് പോയി, എല്ലാം പോയി. ഹരികൃഷ്ണനെ കൂടെ കേട്ടിട്ട് പോകണമെന്നായിരുന്നു. ബിക്കോസ് ദീസ് ആർ ദ ഗിഫ്റ്റ്സ് ദേ ആർ ഗിവിങ് ബാക്ക് ടു ടീച്ചേഴ്സ്. ഇത്രയും നല്ല എക്സലൻസിലായിട്ട്, സിൻസിയറായിട്ട്. ആൻഡ് ഐ ആം ടെല്ലിങ് യങ്ങർ ജനറേഷൻ ടു ഫോളോ ദീസ്. അനിൽ ഹരികൃഷ്ണൻ, മൈ സ്റ്റുഡൻസ്. ആൻഡ് കൃഷ്ണൻ നമ്പൂരി സാർ എന്ന് പറഞ്ഞൊരു സാറുണ്ടായിരുന്നു പീഡിയാട്രിക്സ്. ഹീ സെഡ് വൺ തിങ് അറ്റ് ഈസ് റിട്ടയർമെൻറ്റ്. പേരൻസിനും ടീച്ചേഴ്സിനും അസൂയ തോന്നാത്ത, ജലസ് തോന്നാത്ത വൺ തിങ്, ദാറ്റ് ഈസ് ദ ചിൽഡ്രൻ ആൻഡ് ദ സ്റ്റുഡൻസ് റൈസിങ് എബവ് ദ to a great horizon. They feel always happy. I am also feeling happy. ഒരു കാര്യം കൂടെ പറഞ്ഞു നിർത്താൻ സമയമില്ലെങ്കിൽ, ഞങ്ങളുടെ ശ്രീലക്ഷ്മി, ഞാൻ എന്താ ഇത് ശ്രദ്ധിച്ചു കേട്ടോ, ഇന്ന് ഹെഡേക്ക് ഒരു സിംറ്റമായിട്ടും സൈനായിട്ടും വരുമ്പോൾ വി ഷുഡ് ബി വെരി കോഷ്യസ്. ആ കുട്ടി പല പ്രാവശ്യം തലവേദന എന്ന് പറഞ്ഞ് എൻ്റെ ഡിപ്പാർട്ട്മെൻറ്റിൽ ഇരുന്നിട്ടുണ്ട്. അപ്പം ഞാൻ പറഞ്ഞിട്ടുണ്ട്, കമാൻഡ് ചെയ്തിട്ടില്ല, ഡോക്ടറെ അങ്ങാനും കാണിക്കും. പക്ഷേ ഞാൻ ന്യൂറോളജി എന്നൊന്നും പറഞ്ഞില്ല, തലവേദന ഇടയ്ക്ക് വരുന്നു എന്ന് പറഞ്ഞു. മദർ ഇൻ ലോ ഇല്ലാത്തതുകൊണ്ട് ആ കുക്കിംഗ് രാവിലെ എഴുന്നേറ്റ് അങ്ങനെയൊക്കെ പറയും. അപ്പം ഞാൻ കാണിക്കണമെന്ന് പറഞ്ഞു. പക്ഷേ ഞങ്ങളുടെ CMയുടെ തലേ ദിവസം ഷീ വെൻ ടു ബൈ ഒരു പൊട്ട് വാങ്ങിക്കാൻ പോയി, ബൈക്ക് ആക്സിഡൻ്റായി. അപ്പോൾ എന്നെ ഉടനെ വിളിച്ചു. എമർജൻസി രാത്രി 8 മണി. ഞങ്ങളെല്ലാം ഡിപ്പാർട്ട്മെൻറ്റിൽ ഇരുന്ന് ഓരോന്ന് ഉണ്ടാക്കുകയായിരുന്നു. അപ്പം ഞാൻ ഓടിച്ചെന്നു, പ്രാർത്ഥിച്ച്, കർത്താവേ ഹെഡ് ഇഞ്ചുറി ഉണ്ടാവരുത്, ഷീ ഷുഡ് കം ഫോർ ദ CMA. ആൻഡ് വാട്ട് ഹാപ്പൻ വാസ് എ ഗോഡ്സ് മിറക്കിൾ. നെക്സ്റ്റ് ഡേ ദർ വാസ് നോ ഹെഡ് ഇഞ്ചുറി, but she had a glioma. അത് അന്നേരം ഇപ്പം ഷീ ഹാഡ് ദാറ്റ് ഓപ്പറേഷൻ ഫ്രം, ബിക്കോസ് പൈസയൊന്നും അധികമില്ല. ഞങ്ങൾ ഒത്തിരി പ്രാർത്ഥിച്ചു. വി ആർ സ്റ്റിൽ പ്രേയിങ്. പരശുറാം സർ, ന്യൂറോ സർജൻ, ഹി ഡിഡ് ആൻഡ് ഷീ കെയിം ബാക്ക് ടു ജോബ്. പക്ഷേ ഇപ്പം ക്ഷീണമുണ്ട്, റേഡിയേഷൻ കീമോ അവർ പറഞ്ഞു, ബട്ട് ദേ ആർ ഗോയിങ് ടു ഗംഗാധരൻ സാർ. അപ്പോൾ എനിക്ക് ശ്രീലക്ഷ്മിക്ക് ഓപ്പറേഷൻ ചെയ്തു. അപ്പോൾ ഇതെൻ്റെ തലയിൽ വല്ലാതുണ്ട്. അതുകൊണ്ടാണ് ഹെഡേക്ക് വളരെ പണ്ട് പറഞ്ഞു. ഞാൻ ഓർക്കും ഞാനും അത് കാണിക്കണമെന്നൊക്കെ പറഞ്ഞു, പക്ഷേ ഐ കനോട്ട് കമാൻഡ്. പക്ഷേ because of this accident, but because of accidents only children are also diagnosing with tumors. ഇപ്പോൾ ഈ തലവേദന is a symptom. സതീഷ് ഇവിടെ ഉണ്ട്. ഡബിൾ വിഷൻ ഡിപ്ലോപ്പിയ ഒക്കെ ആയിട്ട് വരുന്ന പേഷ്യൻസ് ചിലപ്പം മൾട്ടിപ്പിൾ സ്ക്ലിറോസിസ് ആയിരിക്കാം, പിറ്റ്യൂട്ടറി ട്യൂമർ. സോ ഒരു അടുത്ത് ഒരെണ്ണം വരുമ്പോൾ വി ക്യാൻ ഹാവ് ഷുഡ് എ കോഗ്നേറ്റീവ് ഇൻറ്റ്യൂഷൻ മറ്റടുത്ത് നോക്കാനായിട്ട്. With simple lab and simple X-ray, we can find so many things. Thanks a lot to the coordinators, John sir and all, for arranging such a meeting.
Sir, one question. Now, nowadays, we are finding a lot of post-COVID headaches. See, how are you going to treat that patient? Because after the COVID, most of the patients are coming with a headache along with the some amount of VC problems. So how are you going to
Most
manage?
of these post-COVID headaches are likely a migraine chronification only, sir. Otherwise, the patients may develop a new onset persistent headache. But overall, the phenomenology is more like a tension type headache or a migraine like headache. We can treat it treat based on the clinical phenotype. If the patient is having a migraine type phenotype, we can give the medications like topiramate may be a good option. Similarly, post-COVID tension type headache, amitriptyline is a better option. So that depends upon the phenotypic expression. Usually this happens in the background of a pre-existing headache disorder. That is like very difficult to control actually. Post-COVID, I have seen 3-4 patients. The headache will not improve with any medication. Very refractory.
But the thing is that when you give steroids for this bronchial asthma or obstructive airway disease, the headache will improve. Once you stop it, again this will
be some unknown mechanism operating. But now that incidence is less. COVID is still present, but it's less.
Any other questions? Thank you, sir. Now I call upon the chairpersons on the dais to hand over the memento to our speaker, Dr. Hari Krishnan. I kindly request the chairpersons to stay back and receive the memento presented to them by Professor Annama Kurian, HOD of Physiology, Believers Medical Hospital.
Just kindly spare just 5 minutes more. We have a few questions with exciting prizes. So it's not a formal type of quiz, mainly targeted at the students and residents. So if I'll project the question here, just raise your hands and you can tell the answer openly. Just raise the hand.
Yeah. Kindly participate. There were no questions from the audience.
Otherwise, the prize will go to the company. Okay, anyone? Status migrainosus is defined when migraine lasts more than?
Okay.
Just one person. I'll
just stand up and raise your hand. That will be ideal.
Okay.
Okay.
Okay. Just.
Okay.
Next question. Symptomatic cough headache is most commonly associated with. Anyone?
Yes,
raise the hand.
Here. One person. Madam, you can.
Anyone? Yeah. Very nice.
So Chiari type 1.
All of the following are MRI image findings of idiopathic intracranial hypertension except.
Please stand up. Please stand up.
Please raise your hands. You know, it's slightly out
one
of
person,
the topic.
You can take the mic and answer. Surya mic. Okay.
No, you can just show me the number.
4.
4, yes, right answer. Pachymeningeal enhancement. So optic nerve, tortuosity of the optic nerves, empty cella, sometimes even partial empty cella, and flattening of the posterior part of the sclera. These are the classical MRI findings of idiopathic intracranial hypertension. The pachymeningeal enhancement is something secondary. Which of the following structures are not pain sensitive?
Yeah. Tinson.
Doctor.
You can stand up.
Very good. Nice. Correct answer. Pyometer. Okay. So, slightly controversial. Classical teaching, durameter, large venous sinus and large arteries of the circle of Willis are sensitive to pain. But there are few newer studies with the craniotomies where they have said sometimes maybe this pyometer might be also pain sensitive. So classical teaching is pain insensitive. Easy question. Which of the following cranial nerves play a major role in?
Yeah. You can stand up.
Yeah. Trigeminal. Everyone knows that. Okay. 100% dose is used for the acute treatment of which headache type? All one chance for one person.
Actually, these 3 people.
Yeah.
You can decide.
Anyone can answer. Yeah, right answer.
You can stand up.
Cluster.
So
So it's not just simple oxygen, 100% oxygen. Just remember that. What group of drugs are regarded as a drug of choice for tension type headache? Anyone? Quick answer.
Okay. You can.
Yeah, she raised her hand. Yes. Answer? Yeah. Okay.
Which group?
Yeah, that's a more better wording for answer. Please.
Okay.
Amitriptyline is right. Which of the following is not a TAC?
Oh, so you can give. So in-house there are marks.
No, just give you. It's okay. Right. All the answer.
Okay. We should give a big hand.
Which is not used for acute migraine treatment?
Okay, raise your hands.
Yes.
Yeah. Madam. Pardon?
Yes. Right answer. You can use ditans, triptans, NSAIDs, but propranolol is used for?
Last question.
Which imaging will you order in the following case? A 29-year-old gentleman with a thunderclap headache started when he was lifting dead weight. Complete. Anyone who has not answered before? Another chance to another one.
One more chance. Yeah. You can.
Yes. Someone stood there. Huh?
CT with contrast.
Okay. What are we looking for? What are we looking for?
MRI.
Not exactly. You are seeing this patient in the emergency setting.
Madam, you can optimize your answer. Yeah, you can. You know the answer.
So you are doing CT. You are giving contrast. Would you like anything? While giving the contrast, would you like to give
one more thing?
Else? Yeah, the vessels.
Okay.
CT angio also. Okay. Right. CT. Okay. Thank you. Now, I think it's time for the vote of thanks.
As we conclude our program, it's time to extend our sincerest gratitude. I'm thrilled to invite Dr. Anil Kumar Shivan, the Organizing Secretary, Neurobites 1, to deliver the vote of thanks.
Thank you, everyone. First of all, I would like to thank God Almighty for giving this opportunity. And the first person whom we should thank is our beloved Director and CEO, Dr. George Andy sir. And Dr. Jomsi, he couldn't come actually. And Professor Dr. John Vellith sir, in spite of his busy schedule, he came. Also, Mini Madam CNO and Reverend Father Thomas Varghese Sachan for giving the prayer. And from my deepest heart, I would like to thank Shahul Hamid sir, because in spite of a very personal commitment, he came. Right, sir? He came, he told that in the Sambhajali session, attend the program on the day. So from the department of, from my own, and from the for the department, I would like to thank him. A special thanks to him. And also, I would like to thank beloved Sharma sir. ഒരു പ്രാവശ്യം വിളിച്ചപ്പോൾ തന്നെ സാറ് വളരെ സാറിൻ്റെ എക്സൈറ്റ്മെൻറ്റ് വളരെയായിരുന്നു. സോ താങ്ക് യു സർ, താങ്ക് യു വെരി മച്ച് ഫോർ കമ്മിങ്. അഗൈൻ ഡോക്ടർ മോഹൻ വർഗീസ് സാർ കുറച്ച് മുമ്പ് പോയി, അഗൈൻ താങ്കിങ് ഹിം. സുനിൽ മാത്യു സാർ ആസ് ഓൾവേസ് എപ്പോഴും നമുക്ക് സപ്പോർട്ടായിരിക്കും. ഐ ക്യാൻ സ്പീക്ക് ഇൻ ഇംഗ്ലീഷ്. എപ്പോഴും നമുക്ക് സപ്പോർട്ടായിരിക്കുമെന്ന് നമുക്ക് എപ്പോഴും ഉറപ്പുള്ള കുറച്ച് ആൾക്കാരുണ്ട്. അതിലൊന്നാണ് മാത്യു സാർ. സുനിൽ മാത്യു സാർ എപ്പോൾ വിളിച്ചു കഴിഞ്ഞാൽ സാർ ഒരു സ്നേഹത്തോടുകൂടി ഒരു ചിരിയോടുകൂടി വരാമെന്ന് സമ്മതിക്കുകയും ഗൈഡൻസ് തരികയും ചെയ്യും. ജേക്കബ് ചെറിയൻ സാറിന് വരാൻ സാധിച്ചില്ല ആരോഗ്യപരമായ കാരണങ്ങളാൽ. പ്രൊഫസർ എസ് കെ മാത്യു സാറിന് വരാൻ സാധിച്ചില്ല. താങ്ക് യു ഡോക്ടർ ഫിത ആൻഡ് ഡോക്ടർ ഫാഹിമി, ബിക്കോസ് they came personally and they brought, I think, 10-15 people along with them. Thank you. ഫിലിപ്പ് തോമസ് സാർ തിരക്കായതിനെ കുറച്ച് മുമ്പ് പോയി. സാറും എപ്പോഴും നമുക്കൊരു ബ്ലെസ്സിങ്സ് പോലെ നമ്മുടെ കൂടെ നിൽക്കുന്നവരാണ് ഫിലിപ്പ് തോമസ് സാറ്. സാറ് പിന്നെ പറയുകയും ചെയ്തു, ഇത് കണ്ടിന്യൂസ് ആയിട്ട് നിങ്ങൾ നടത്തണം. 1-2 ടോപ്പിക് സാറിന് സജസ്റ്റ് ചെയ്തു. സെക്കൻഡായിട്ട് എന്താണ് റൈറ്റ്സ് 1-2 സോറി നമ്പർ 30 സാർ പറഞ്ഞു. ഞാൻ ജസ്റ്റ് വോട്ട് ഓഫ് താങ്ക്സ്. അഗെയിൻ I would like to thank Jensi Madam and Sadish sir and Joseph Jones sir for coming and sharing our sessions. Again, ഈ ഒരു കാര്യം പറഞ്ഞപ്പം എനിക്ക് തോന്നുന്നത് ജോൺ സാറിൻ്റെ ഐഡിയ ആണ്. എനിക്ക് തോന്നുന്നില്ല അതെ, ഇത് ജോൺ സാറിൻ്റെ ഐഡിയ ആണ്. അപ്പം ഈ തുടക്കം മുതലേ ഞങ്ങൾക്കൊരു സപ്പോർട്ടായിട്ട് ഒരു ഗൈഡൻസും ഒരു മാതൃകയായിട്ട് നിൽക്കുന്ന സാറിന് നന്ദി പറയുകയാണ്. അതുപോലെ തന്നെ കഴിഞ്ഞ ഒരു 2-3 ആഴ്ചയായിട്ട് എനിക്ക് തോന്നുന്നു ഡിപ്പാർട്ട്മെൻറ്റ് ഓഫ് ന്യൂറോളജി മൊത്തം ഇതിൻ്റെ പുറകെയാണ്. അപ്പോൾ എല്ലാവരെയും ന്യൂറോളജി ഡിപ്പാർട്ട്മെൻറ്റ് എല്ലാവരും എൻ്റെ വ്യക്തിപരമായ പേരിലും ഡിപ്പാർട്ട്മെൻറ്റ് പേരിലും ഞാൻ നന്ദി പറയുകയാണ്. സെക്കൻഡ്, ഈ ഒരു ഓഡിയോ വിഷ്വൽസ് ഓപ്പറേഷൻസ് ബെഞ്ചമിനോട് പ്രത്യേകിച്ച് നന്ദി പറയുന്നു, റീനുവിനോട് നന്ദി പറയുന്നു. പിന്നെ സാറേ സിജു, അയ്യോ തുടക്കം ഈ ഒരു ഇതിൻ്റെ മീഡിയ പാർട്ടെല്ലാം മാനേജ് ചെയ്തതും ഇൻവിറ്റേഷൻ പാർട്ടും എല്ലാം മാനേജ് ചെയ്തതും ഈ ബ്രോഷർ അങ്ങനത്തെ കാര്യങ്ങളെല്ലാം ചെയ്തു തന്നത് സിജുവാണ്. അദ്ദേഹത്തിനെയും ഈ അവസരത്തിൽ നന്ദിയോട് ഓർക്കുകയാണ്. താങ്ക് യു. സെക്കൻഡ്, പുതുമുഖങ്ങളാണ്, കുറച്ച് പേര് പുതുമുഖങ്ങളാണ്. ഞങ്ങൾക്കൊരു ഡിപ്പാർട്ട്മെൻറ്റ് സെക്രട്ടറിയെ കിട്ടി. ഷീജയും വളരെ ഇൻസ്ട്രുമെൻ്റലായിരുന്നു ഈ ഒരു പ്രോഗ്രാമിൻ്റെ മുമ്പിൽ പുറകിൽ നിന്ന് പ്രവർത്തിക്കാനായിട്ട്. താങ്ക് യു വൺസ് അഗൈൻ. സാർ, അടുത്ത പ്രോഗ്രാമിനെ പറ്റി പറയാൻ സാറിനെ വിളിക്കുകയാണ്. എല്ലാവരെയും ആരെങ്കിലും വിട്ടുപോയിട്ടുണ്ടെങ്കിൽ, പിന്നെ ഏറ്റവും പ്രധാനപ്പെട്ട ആൾക്കാർ പറഞ്ഞില്ല, പാർട്ടിസിപ്പൻസ്, നിങ്ങളോട് എല്ലാവരോടുള്ള നന്ദി രേഖപ്പെടുത്തുകയാണ്.
So with your blessings, we will continue our teaching series, Neurobites 2nd. That's the topic is epilepsy. We will be conducting on November 30. Thank you very much. Thank you. So now, lunch.
As we wrap up this informative session, I want to extend a sincere thanks to all the speakers and delegates. Your engagement is what makes these programs so valuable. Before we part ways, we invite you to join us for lunch arranged in the Medical College block, top floor break. If you have any queries, please approach our registration counter outside the amphitheater.
Certificate will be available for pickup at the adjacent reception counter. We kindly ask your patience as our organizing committee works efficiently to distribute them to you. Thank you for your understanding and being a part of today's event.
We have kept the feedback form in the files. Kindly take some of your time to fill it out, and please give it back to the organizing committee at the registration counter as you went to collect your certificates.
Please, ellarum feedback form tharanam. Your opinions are so valuable for us to improve in the subsequent sessions. Valare open ആയിട്ട് നിങ്ങൾക്ക് എല്ലാ സജഷൻസും എഴുതാം. Please.
Thank you once again for being here, and we look forward to seeing you at future CME.